Hello, everybody. Welcome to another edition of Voices Interviews, where we interview authors from our latest edition, Volume 20, Number 3, available now at voices.no. This evening, I'm excited to have the authors of the article Program Directors' Perceptions of the CBMT Exam, Dr. Anthony Meadows and Dr. Lillian Eyre. Tonight, we'll talk about the results and implications of a survey they conducted, which elicited 41 academic program directors' perceptions of the Certification Board for Music Therapists Board Certification Exam. We will reflect on the results, not only within the context of the United States, but also looking at it globally and the implications of gatekeepership in music therapy. Please welcome our guests. And thank you for joining us and for being here to talk about your article. And would just like to start off with introducing yourselves and letting us know the impetus for you conducting this survey.
Okay, well, I will start. I'm Lillian Eyre. I was the director of music therapy at Immaculata after Dr. Meadows left. And I am now a professor at Temple University. I am a non-tenure track visiting professor, and this is my third year at Temple.
And I'm Tony Meadows. I direct the music therapy programs at Shenandoah University. I have been working as a clinician for many, many years, first with children with disabilities and more recently in cancer care. And Lillian and I have worked together at Immaculata for a number of years, and we've continued that relationship as co-researchers on a number of projects. We come to this project, at least I'll share how I've come to the project, and Lillian can share her perspective as well. Actually, at the initial impetus came from for this project when we were faculty at Immaculata, which is in Pennsylvania, for those not familiar with the university. And what we noticed at the time was that some students who we considered to be really clinically strong students, they had really successfully completed their practicum and internship experiences. They received really very strong evaluations from their internship supervisors, but they struggled to pass the CBMT exam. And we wondered what was happening with those students. Was it something about what we were doing as teachers that wasn't properly preparing them for the exam? Was it the fact that they might not be very good test takers, or was it something else? And we could never really work that out in our time together at Immaculata. And when we started off in different positions, we continued to talk about that. And in fact, we discussed the meeting a couple of years ago at the American Music Therapy Association National Conference, when the executive director of the certification board actually spoke and talked about declining first-time test scores. And this was a really important moment for us because it really rekindled questions that we had about the CBMT exam and about the struggles that we continue to see in our different roles with students passing the exam. And so we felt at the time that we wanted to just focus on one piece of that, and that was the experiences of other program directors in similar roles to us, and what their experiences were shepherding students through their education process in the exam process, and how successful we saw those students in actually passing the exam for the first time.
Lillian, do you have anything you would like to add to that?
Sure. I came at it from 2 points of view. One was that I was actually not allowed to do the exam as an immigrant from Canada, even though I was on the board for certifications in Canada. And so when I came here to do a PhD at Temple, when I finished the PhD, I was allowed to sit for the exam. And I remember an esteemed professor of mine saying, gee, I hope you're going to do okay. And I thought, do you not trust me? And she said, well, no. She said, it's not that. It's quite the opposite. I'm concerned that your level of knowledge is going to be too deep to let you pass that exam. And I thought that was rather strange until I did the exam, in which I spent most of the time. They have a place where you can create, where you can respond to them about your feelings about it or your thoughts about the question. And for many questions, I said, this could be answered in so many different ways. And I kept responding to the questions that way. I passed the exam, but there were a couple of areas where I probably spent too much time commenting. And that stuck with me, that it was a very strange exam. And what simply struck with me was my great relief at passing it and how different it was from actual clinical work. And at that time in Canada, we had what could be an alternative process, was that we had to hand in a dossier of case studies and just a whole range of papers and studies about our clients in order to pass, and that was evaluated. And that was a much more qualitative way of determining a person's ability. So that was the first thing. The second thing was that in about 2017, whereas at Immaculata, we had every graduate student had passed the exam, save for one the first time, or every equivalency student. And the undergraduates, there were very few who didn't pass, and except for a couple who were really, really excellent clinicians, but who thought in a very nonverbal and creative way, they didn't pass. But normally we could predict, students who might have difficulty according to their GPA. So the students who were really, that Dr. Meadows and I both thought were really good students clinically, those two students we were thinking of didn't pass, and that was confusing. And in 2017, suddenly almost everyone was failing. I mean, we had a very, very low pass rate, and that really made us wonder what was happening. And that's when we discovered that the cut scores had been changed, although that shouldn't have made such a big difference. And that drove us to look at the exam in more depth and to try to understand what it was doing, what it was testing.
Yes, and as an educator in the United States myself, I certainly resonate with your experiences, and wondering, as an educator myself, is it us? Is it what we're doing? And so it's appreciative that to look at the program directors, say, is it, are you experiencing the same thing that we are experiencing? What are your experiences here? And so that we could start to come together as faculty to understand what the experiences of students are as they move into the profession within the United States.
Exactly.
Sorry, go for it, Tony.
Yeah, I think, Mike, I think that for listeners who are not from the United States, because of your international scope with Voices, that we're experiencing in the United States really quite a challenging educational environment, that perhaps is a part of this frame for us when we're thinking about the CBMT exam. So certainly at Shenandoah, we see this, and Lillian and I saw this together when we worked at Immaculata as well, that students are experiencing financial stress. A lot of students, it's very expensive to receive an education in the United States, that they're often working jobs, that they're managing all these different parts of their lives, including their mental health as undergraduates, that is a real challenge for us as educators to support. And those challenges seem to be getting more and more complicated, of which COVID, in many ways, that we're experiencing at the moment, has kind of amplified some of those challenges and some of the disparities between students, especially economic disparities. And so I think a part of the reason that we have focused on the CBMT exam is an ethical one, and that is that to what extent should we be vetting students' academic competence before they start the program, so that they don't go through 4 or 4.5 years of an academic training program and then they're not able to pass the exam at the end. I think as faculty, we feel a tremendous responsibility of supporting students through this process, and really feel terrible when they're not able to pass. And it's a self-questioning process for sure, but it's also one in which there's this kind of ethical component about what the heck is happening.
Yeah, it feels as you both have been talking, I start to think about, within the United States and the history of wanting to use multiple choice tests as a form of gatekeeping from one situation to whether it's, high school students taking the SATs to get in, or the GREs within the graduate tests to move into places as the form of, so as a standard,
Yeah.
as a statistical standard, and how in in a lot of cases, those kind of standardized testings are being challenged and replaced in a lot of contexts. And there must be a history of that, especially within the United States context, of why that kind of gatekeepership, which is so limited in terms of knowledge and ability and, the ableist kind of framework within that kind of gatekeeping. um, it says a lot to me about the context in which we live in the United States. No, I was wondering if that resonated with you, given a historical and cultural context to that type of thing.
Yeah, I absolutely, that really resonates. And Tony and I were having a discussion about this previously when, it turned out that University of California had done away with their tests and that they were not going to use graduate testing any longer. And in 2 years or 2 or 3 years, they're going to try to come up with their own test. And if they don't, they're not going back to it. And much of this is because of everything, all of the upheaval that's been happening, not only in the States, but the world over, realizing our ableism contexts. And when we think about the history of these tests, really, what were they created for? They were created to help middle and upper class white men be able to access the halls of upward mobility, and to keep out women and any people of color, and particularly African Americans in the States. And that is the basis of these tests, and the way that they have been constructed has essentially not changed. So as the AMTA and as globally we look at what is diversity, what is inclusion, what is ableism, how can we make our profession more open to people, and encourage and encourage people from different races and different backgrounds to become music therapists, because we are treating people from different races and different backgrounds. And yet this exam seems to be a barrier for English, non-English, non-first English learners, shall I say, even if they have learned it from a young age, tend to not do well in this exam, and for very different kinds of learning. And in fact, we were talking about the number of people who have been failing, and it seems that only 70% of students pass the first time. And if they don't pass the first time, they have a 31% chance of not passing ever after. So if you think about that, if you do the math, I think it comes around to 10% of all students who would do the exam would not eventually be able to practice music therapy. That seems like a lot, and I haven't compared it to other fields, but that seems like a lot of people who are racking up debts and then can't practice.
And as you said, some of them might be very strong
Absolutely.
clinicians, as experienced within the classroom. I was wondering how you went about framing your survey questions, and how you went about asking, knowing that these contexts might be within, or your understandings of coming into it, how you went about coming up with the survey, and what you were hoping for as you were coming up with the survey. What were your intentions during that process?
Well, we took a really practical approach, Mike. We were primarily interested in understanding what the experiences and the perceptions of program directors were. So in the United States, there's about 86 approved AMTA approved programs. There was a few less when we did the survey. So we sent the invitation out to 82 to academic program directors, and 50% of those responded to the survey. So we had about a 50% response rate. And we focused on academic program directors because we felt that they had the broadest perspective on the training of students, because they were actually managing and running and conceiving of the programs primarily. Even though as faculty in the United States, we're all involved in that, we felt that this was an appropriate place to start. And we asked them a series of questions about their perceptions of the exam in evaluating clinical competence. We actually did ask 2 questions about the cultural frame and the extent to which the exam was culturally sensitive. But what we found, interestingly enough, when we actually reviewed the survey findings, was that most faculty members didn't feel they could actually respond to that question, because one of the challenges of the exam in the United States is that as faculty, we don't actually have access to the exam. And so there's lots of really good reasons from that, from a management of the exam perspective. And but the challenge from the other side of that is that we actually don't know the content of the exam firsthand unless we take it ourselves, in which case we just have a certain kind of experience of that. So one of the challenges that we have had to deal with, both in the construction of the survey and knowing what our colleagues' experiences of the exam is, that we as faculty don't know the content of the exam, and we can only perceive the relevance of, and the meaningfulness of the exam from our own perspective as faculty members. And to us, this is essential because this is the way we experience the relationship between the academic program and the exam itself. It's a way of perceiving of it through our students' experiences. And we're trying to understand the experiences of our students of the exam in relationship to our experiences of our students in their clinical work, and trying to make sense of these 2 things as they connect to the construction of an academic program. With pieces of that puzzle missing for us here in the United States, the access to the exam being, of course, the primary missing piece. But we're also experiencing it through the student's perception of the exam, which is always a particular kind of lens as a student, and our secondhand experiences of those things. So it creates some real challenges, I think, for a number of faculty in how to deal with the relationship between the exam and their clinical program and the students' clinical competence.
In the United States in particular, you know, where we have an entry level at an undergraduate, it's an entry level exam at the undergraduate level. And of course, many universities have graduate equivalency that, you know, will take it at the end undergraduate or the entry level and then continue with advanced coursework at the graduate level. I was just curious as to how the survey asked or went about that aspect, because it would seem to me that the learners and those categories are certainly very, very different and have different life experiences. You know, everybody, all of the learners, whether they're undergrad and younger or undergrad and more mature or graduate equivalency, and in different life phases, are very busy and stressed financially, workload and everything. How did you go about tackling that concern?
So, I mean, essentially, you can't separate them out. For the exam, the equivalency are considered to be entry level. And what we noticed, though, was that the graduate students, even though at Immaculata, we would accept students who maybe didn't have a music degree as a background, and we would supplement that with because it was a music school. But for those students, they tended to do much better simply because of their life experience and their other learning, even when it wasn't music or music therapy specifically. Even though they may have had really rudimentary theory and rudimentary history, all of those things that are such bulwarks in the undergraduate curriculum, they did quite well without those. And what this brought up for everyone was the issues with the practice analysis and how is it created. So because the CBMT needs to have approval from a number of certifying agencies to make this exam a certification exam, they have to go through particular processes to make sure that what is being tested is actually what is out there in the clinical world. And so they have what is a practice analysis in which they randomly choose a number of people, send them a survey about what they are doing in their work. There are two problems. One is that, first of all, the survey doesn't really give you too much space to talk about what you do that might be different. They've already identified everything and you're checking yes and no, or the extent to which I use this, etc. And so you are forced to think in that frame, even if as a clinician, doing the practice analysis for me, it was very hard because as a clinician, I don't think in that frame. And the other problem is that with the practice analysis, there is no transparency, and they might be doing a great, stand-up job, but there is no transparency about who is taking this exam. So what the program directors found was that there was some concern about, are the questions that are based on the practice analysis, are they based on people with a lot of experience? And so many of the people who might, even if they say we're only doing it with people in the first year of practice, are they separating out people who are equivalency and people who are undergraduate? Because those are two very different learning systems. It does not appear to be so from anything that I've read, but again, there's not a lot of information. The second thing is, are they using people who have real specializations, who have learned specializations like GIM or NMT, and are they using those as typical responses or tasks of a music therapist? Thirdly, are they looking at, I forget the other two, but so are they looking at specialization? Are they looking at people who have had long experiences? And are they really looking at what is actually required only in the first couple of years of practice? Or are they looking at people who have had specializations in internship sites? We see a lot of, and we hear about a lot of really specialized medical terminology. If you think about teaching one methods course in medicine in a typical undergraduate program, you have a lot of area to cover and you can't really get into a lot of specialized medical terminology, nor is that really necessary, because anyone who would get a job in a medical unit would learn that terminology there. So there are a lot of issues with making this distinction between various levels of practice, including equivalency and undergraduate.
Yeah. The moving into, because you've talked a lot about both various discussion points and hit upon some of the results, but I was curious as we go through the results of the survey, what really stood out to you, or what did you find most striking in terms of the survey results?
Well, I think we saw two different kinds of pictures that were painted by the survey findings. The first is, we asked a series of questions that participants were invited to respond to along a scale from agree to disagree, or those kind of valences. And when we looked at the responses to the questions about the extent to which program directors felt that the exam evaluated clinical competence, and other kinds of variables related to students' experiences of the exam, the average response was to neither agree nor disagree. And that this suggested a couple of different things to us. The first is that we saw that in the individual response findings, there are about a third of people who tended to agree, for example, that the exam was a valid measurement of various aspects of clinical competence. About a third that tended to disagree, and about a third of those that were unsure would neither agree nor disagree. Which suggested to us that the folks that responded tended to fall into three different kinds of perspectives: a disagree, an agree, and I'm not really sure. And that they were pretty evenly distributed, so that the averages tended to not show these kind of differences, but it said that in the end, there's no clear kind of picture. So that's the survey responses themselves. When we looked at the qualitative data, we found really a much clearer picture of concern. And that there were two key components to that, which we've actually talked about already, but I'll just go back over those again. The first was that a large number of written comments that expressed concerns about the construct validity of the exam, the extent to which it's measuring clinical competence in essence. And the second has to do with the extent to which passing the exam has to do with a person's ability to be able to successfully take a multiple choice test. So, so when these written responses, and there were a lot of them from the respondents, which suggested to us that this was an important thing for participants to comment on, that the vast majority of those responses expressed concerns of one form or another, and that the top two responses were those two things. So the takeaway for me was that there are three different kinds of perspectives amongst response participants: those who feel the exam is a valid measure of clinical competence, those who are unsure, and those who feel that it isn't. And when asked to express their views about the exam overall in a written format, the majority of people expressed concerns about the exam.
I think the number was 85% agreed that changes within their open questions, 85% had mentioned that changes were needed, even if they kind of neither agreed or disagreed.
That's right.
With what was happening. They all agreed that something does need to happen.
Yeah.
Regardless. Yeah, that was a pretty striking number. Lillian, you were going to add?
No, it was just very interesting to see how all of the program directors were trying to be so fair, and basically why all of the quantitative, all of the Likert type questions came back as sitting right in the middle. It was because it's really hard to say. I don't know for sure.
Yeah.
But when you ask them about, well, how do you feel about it? What are your thoughts about it? That's when it came pouring out. And it was pretty consistent that about 23% feel that everything is just fine. 15% actually feel that everything is just fine. There are a few who vacillate, but 85% said that there's a lot of need for change. Not that the exam should not be there. We need something, and most people reiterated that fact, that they really did want something in its place, but that there was a great deal of angst and concern about how this exam might be a barrier in our profession, and that it had repercussions for our clients. And it certainly is affecting our students and diversity within the profession.
You've talked about a lot of the discussion points already throughout this interview, about the changes that may be needed and how to address it. But I was just wondering if you could, what are your thoughts about moving forward? Your discussion section brings up so many points, each one of those points are a world unto themselves, it really feels like.
Well, I'll start. I want to talk about construct validity in some ways, because I think this was one of the things that we really talked about in the discussion as perhaps being important to thinking about our future in the United States and the future of the exam. We wondered whether the levels of agreement, especially with the survey questions, actually reflected a philosophical position of those people that responded to the survey, and that there appear to be at least some program directors that philosophically are really aligned with the exam and aligned with the way that the exam is asking questions about competence. And while we didn't ask specifically the kind of orientation that respondents believe the exam takes, that when you speak with faculty and you hear colleagues talking about the exam, in general they tend to view the exam as something which is either cognitive behavioral or behavioral in orientation. And that I think that this to me is a really important starting place for discussions about the exam and about the future of the profession. And it could be something that could be resolved or further explored just by CBMT data. But the perception that I have about the exam, and that certainly is shared by many faculty, is that theoretically the exam is cognitive behavioral. It privies one kind of orientation to clinical practice at the exclusion of others. And as Lillian suggested in the construction of the practice analysis, that when you conceive of music therapy practice as a series of tasks, then there's an implied theoretical perspective that comes with thinking about music therapy as tasks. And that to me, this is something that we really need to talk about as a profession, is music therapy clinical practice a series of tasks? Is there a right way of responding to a clinical situation? And is the impact of music on the health of a person causal? If you believe the answer to these questions is yes, then you probably are more likely to feel comfortable with the exam as a measure of clinical competence. But as we've experienced in our own work, and I think as the international listening community is probably likely to attest, there's more than one way of practicing as a music therapist. And that there's more than one context in which music therapy clinical practice happens. And in fact, even within the same clinical context, different clients may require us to respond in different ways to serve their health needs. So if you're of this belief system, then it makes causal approaches to practice and reducing practices to a series of tasks a more challenging way to think about clinical practice, because it doesn't fit it with context. And this is something that I think we've not really discussed a lot as a profession in the United States. And my perception of that is because it's a difficult conversation to have, because it reflects a theoretical perspective, and that we don't have a shared agreement about theoretical perspectives and about how to talk about differences of theoretical perspectives. Because I think historically that once we've talked about a theoretical perspective, there's a set of values that go with that, and that tends to, or at least it's historically tended to, create conflict, not open communication. And my sense is that our discussions about the CBMT exam and faculty's perspectives about the CBMT evoke these same kind of reactions from music therapists in the United States. it creates conflict, and that I think that we as a profession will benefit from being able to talk about clinical practice in a multitude of ways that doesn't privy just one perspective. And if that's the world that we can live in the United States, then we have to question the exam and its ability to evaluate different clinical perspectives.
In some ways, it feels like the results are a reflection of the Likert scale results versus the open-ended question results. Feel like I kind of a peek into that of we don't know how to really talk about it. I'm not quite sure I agree or disagree where I stand on it, but something needs to happen. And the more we sit within the tension of not knowing if we agree or disagree,
Yeah.
the more tension will build, because it's clear that something needs to change, and yet no one knows how to go about that change. Lillian, would you like to add?
Yeah, I would just add to that there's also the immediate problem of the undergraduate curriculum, which, going way back to when we were doing the literature review, way back to the mid-70s, when educators were saying, look, we started off in a music program adding some courses on therapy. We need to move out of this, and we need to make it a therapy curriculum with some courses in music that we need. And it is still not changed. And the more that we add the tasks in the domains of the CBMT to the curriculum, the more difficulty we have. And then we have another huge split in that, and all viewers might not know this, but the CBMT, who administers the exam, has one purpose, and that is to administer the exam and to provide certification for the profession and to protect clients. The AMTA is the education. And so when a university is approved, when a program is approved by the AMTA, they have to include in all of their syllabi all of the AMTA competencies. The domains that the CBMT uses for their exam are different. And the domains are like a huge list that every 5 years they add on about another 30, 40 items. The other problem with that is that Schneck, when she was speaking to the faculty forum about the cut scores and the problems, stated that she was concerned herself because she saw that there were aspects on the board domains that were included in the advanced competencies only. So advanced competencies are for master's degrees, not even equivalency degrees. So that brings up the whole question again about, here we have this curriculum for music therapy with all of these areas of learning that we cannot address because for the most part, we are, and there are some programs that are different, but for the most part, we are within music programs. And very often those music departments depend on the music therapy students to create their music programs, their ensembles, their theory courses. So they are not going to give up on letting us choose courses and design a curriculum for 4 years that would give us a fighting chance at preparing our students to be music therapists. And that is a big problem. And so the problem between the AMTA and the CBMT, who are supposed to be two organizations that do not have any influence on each other, and the faculty in between, this is a problem. And I understand that the structure is there to protect us, but it feels like it's doing the opposite.
Well, thank you. Yeah, thank you both for those thoughts. Very important to consider, especially in the context of the United States, and was wondering for those viewers and readers in other global contexts, any considerations of a survey like this within, for other educators and people who are considering that step between education and professional world, what what may they consider, because their contexts are obviously very different within other areas. Any thoughts about this within a more global scope?
My thoughts would be that I'm very, very interested to learn how other countries approach this issue of taking care of clients, that you're the gateway, and how do you provide assurances that clients are going to be safe and that music therapists are going to be competent. And so what are the approaches? Perhaps there are other approaches that are working very well that we don't know about. And I would be really interested to know how other countries have handled this.
I think we as a profession in the United States it feels like at times in a double bind, in that I think one of the benefits of the CBMT exam and how that's linked to things like state licensure is that it's certainly helped to support the growth of music therapy in the United States, and it's certainly helped to address things like reimbursement and insurance, which are all key things in the United States that help the profession to grow. So that those countries like the United States, where there's a private health insurance system, the CBMT exam serves an important mechanism as a gateway to insurance reimbursement, as a gateway to state licensing, which there's been myriad benefits of both of those things in the United States. But there's also been a cost as well. And the cost is around the extent to which the exam helps to promote the breadth of music therapy in practice, and the extent to which the exam, by its very nature of a standardized multiple choice, is reductive in nature. The expansive versus the reductive nature of standardized testing is something that I think has not been fully grappled with in the United States, and would certainly be a consideration for music therapy associations in other countries. I think the second thing has to do with the way that music therapy is defined in the United States, and the extent to which that definition provides enough flexibility and enough openness to embrace the myriad ways in which music therapy is practiced, and the extent to which it tends to privy one kind of way of thinking about music and health. And that, for me, the way in which music therapy is defined in the United States, and the way that the CBMT exam provides a gateway into music therapy practice are interconnected, and that they're worthy of further examination and further critical reflection in ways that help us to more fully grow music and health in the United States in ways that might not necessarily align with that interconnectedness of definition and certification exam, and that they represent, I think, a kind of fork in the road. At least it feels like that at the moment. I wonder if the experience of going through it will be different. One which tends to privy a medical kind of causal component orientation of music therapy, and one which is not that perspective. Other kinds of perspectives which are more holistic, synergistic, and contextual. And that in the United States, I think we're at a point of grappling with that, but may not yet have the language as a community to be really able to engage meaningfully in those conversations. And that grappling may be meaningful for other countries, or it may not be, because of the political and the health care context in which those countries are living in. I think certainly socialized medicine in other countries provides different kinds of opportunities and challenges that are very different than the kind of challenges that we're facing in the United States with a privatized medical system.
Yeah, absolutely. And sometimes I worry that the system and the political landscapes move in a way that we may not even be able to keep up with as a profession because we might be stuck on one conversation that we need to move through in order to address. So for instance, in each state we talk about needing licensing, and licensing comes with state legislators needing to understand how harm is done. But yet even understanding how harm is done in our profession takes a lot of theoretical perspectives, and so it's not a medical harm. And if we think about it in that way, which is what probably most state legislators are looking at in terms of the viewpoint of harm. But those conversations, we don't even know necessarily how to address yet, as we just go for the goal of state licensure or certification or whatever the end goal is. We may be missing a lot of rich depth dialogue to make our profession really complex.
I think that's right, Mike. And I think that this is where additional CBMT data about the exam would be really helpful. And one of the types of data that I've already talked about is construct validity, but the second type is predictive validity. And that is that music therapists who have the CBMT practicing ways which are safer than those who are practicing using music who don't have the CBMT credential. So there are other data that I think that would be valuable for CBMT to share that will help us understand the benefits of the credential, especially in terms of safety.
As we're wrapping up, I was wondering if are there any discussion points that you feel like we haven't hit upon that feel very important for viewers and our readers to make sure they walk away with or go away with as they read this?
I mean, I think the important thing is that we're able to discuss the things that are there, the things that we know, that we can see, and that are there, that we can see that they need to be fixed. So for us to pretend that a lot of students are failing, and it's just that they're not good and they basically shouldn't have been there. If that's the case, then what is this shouldn't have been there? And so there are a lot of things that we're not discussing that we need to discuss. This is one of them. And the other issue is that how do we go forward and have a discussion which isn't stalled, as you mentioned, that we keep going around in circles with everyone stating their opinion. So we need to figure out a way as an organization to move through discussions without getting stalled because not everyone agrees, because we don't agree. Well, thank you, Mike, and thank you to Voices for taking this very American survey on. I think that it is important for all of us to think about who we are as gatekeepers, what our responsibility is to our clients, and what our responsibility is to our students. And sometimes those that can create some gray area for us ethically as well. And so thank you to Voices and to you for allowing us this opportunity to speak and to publish.
Thank you for watching, and we look forward to seeing you again for our next Voices interview with Carrie Byers and her article Considering Abramson's McMusic Therapy McMarketing article, A Personal Reflection, where we'll have a special guest, Dr. Brian Abrams, joining us. We'll see you then.